Myself, Dr. JIBRAN Ahmad presents to you Simply Pathology, and today we are back with a very important session. Today we are going to read about cytochemistry. Now, cytochemistry is a very important topic in hematology, and every year, one long answer question, comes from cytochemistry, and a lot of viva questions are asked on cytochemistry. Unfortunately, this is also one of the topics which is most neglected, by all the residents, So please understand that this is a very simple and easy topic to understand. So please do not skip this topic for your exam. So without wasting any time, let us begin today's topic of discussion, cytochemistry. Now, always remember that cytochemistry, always when we are using the term cytochemistry, usually most of the residents, they think about leukocyte cytochemistry. But remember, there is also erythrocyte cytochemistry, which involves detection of siderocytes and sideroblasts, as well as detection of hemoglobin derivatives. So what is the meaning over here? The meaning over here is that we are using cytochemical methods for detection of sideroblast, both the normal abnormal variants as well as the hemoglobin derivatives. And in today's lecture, that is part 1 of cytochemistry. In part 1 we are going to discuss in details about erythrocyte cytochemistry. In the next part, in part 2, we will discuss about the leukocyte cytochemistry, wherein we will discuss about myeloperoxidase, Sudan black B, NAP score, acid phosphatase with tartrate resistant acid phosphatase reaction, PAS stain, esterases, toluidine blue stain. So all these different cytochemical stains will be used, and will be discussed in details, and what is the use of each one of them and what is their role, in leukemia classification as well. We will read in detail. So without wasting any time, let us begin today's topic of discussion, that is erythrocyte cytochemistry. Now, the first thing that you have to understand, that over here the first variable that we are going to understand is the concept of siderotic granules or siderotic material, and how do we detect them. So the first important thing that you have to understand, that what is the siderocytic granule or a material. It is nothing but it is a non-heme iron. Basically it is hemosiderin, usually it is hemosiderin. Now, when this siderotic granule or siderotic material is present inside an RBC, we use the term siderocyte. And when it is present inside an erythroblast, we use the term sideroblast. So I hope you understand the concept of siderocyte. So RBCs containing siderotic granule or material is called as a siderocyte, and erythroblast containing siderocytic material or granule, they are called as sideroblast. Usually the siderocytes, the term, they are basically seen in the peripheral blood, whereas the erythroblast, they are mainly present in the bone marrow. So sideroblast is the term referring to erythroblast present in the bone marrow usually. So this is the basic concept. Now first you have to understand what is a siderotic granule. So as I told you, it is a non-heme iron. Basically it is hemosiderin, which is nothing but a water insoluble complex of ferric iron, lipid, protein and carbohydrate. Now how do you detect this siderotic granule? So one method, which is a very commonly used method, that is the Pearl stain or a Prussian blue reaction that is there, wherein this siderotic granule is made to react with potassium ferrocyanide, which gives a blue colored compound ferriferrocyanide, which is referred to as the positive Prussian blue reaction, also called as the Pearl's reaction. Usually this reaction is basically, this Prussian blue stain or Pearl's reaction is mainly carried out in the bone marrow films or bone marrow smears, and it is done for the detection of basically iron inside of, or for detection of hemosiderin inside of the macrophages, or inside of, just lying down also inside of bone marrow, and also done for detection of siderotic granules. Now second important thing, these siderotic granules, they can also be detected by means of Romanovsky dyes, where they are basically with the help of Romanovsky dyes, the siderotic granules, they appear as basophilic granules, and these are termed as Pappenheimer bodies. These are usually termed as Pappenheimer bodies. So Pappenheimer bodies is nothing but it is a form of siderotic granule only. So we are using this term when we are staining that particular siderotic granule with the help of a Romanovsky dye. Then we are using the term Pappenheimer body. And usually this kind of stain is applied in the peripheral blood smear, but it can also be applied in the bone marrow films as well. So the important thing is, whenever you are highlighting the siderotic material with the help of a Romanovsky dye, they appear in the form of basophilic granules, and they are called as Pappenheimer bodies. So Pappenheimer bodies, they are nothing but siderotic granules only. Okay, and what are the siderotic granules? These are non-heme iron, basically hemosiderin. Now, before we go any further, first of all, I would just like to revise certain important concepts, that there are two important storage form of iron. Okay, so physiologically, the first important storage form of iron is ferritin, which is present in all cells of the body normally. Okay, the second important form is hemosiderin. So normally, okay, some amount of iron is stored in the form of hemosiderin. And where do they appear normally? Normally they are present inside the macrophages of the mononuclear phagocyte system, that is the bone marrow, liver and spleen. So normally hemosiderin in small amounts are present inside the macrophages of mononuclear phagocyte system, that is the mononuclear phagocyte system or the macrophages of the bone marrow, liver and spleen. Not only that, some amount of hemosiderin is also lying, normally in the free state as a collection inside the bone marrow as well. So this is what is seen normally. Okay. But in conditions of iron overload, for example, hemochromatosis or transfusion related conditions, okay, transfusion related excessive iron overload if it is there. So in those conditions, hemosiderin starts to deposit in other tissues as well, and that condition is called as systemic hemosiderosis. So this is the pathological condition. So whenever the storage form of iron, okay, in the form of hemosiderin, okay, is the getting stored in sites other than the mononuclear phagocyte system and in quantities far greater than the normal quantity, it is always pathological. Okay. Okay, and in certain conditions, if you see like in iron deficiency anemia, hemosiderin is absent inside the MPS system of the bone marrow, liver and spleen. Okay, so this you have to understand, that normally where the iron is stored, normally iron is stored in all cells of the body in the form of ferritin, and normally very few amount of iron is stored in the form of hemosiderin inside the macrophages of the MPS system, and very less amount can be present scattered inside the bone marrow as well. But very importantly, in conditions of iron overload, okay, this hemosiderin starts to increase inside of the MPS system, inside the macrophages. Not only that, they will also start getting deposited in other body tissues, leading to a condition called as systemic hemosiderosis, and that is pathological. And in conditions of iron deficiency anemia or an iron depletion conditions, also you will see that there is absence of hemosiderin. Okay, so basically I hope this concept is crystal clear to everyone. Now remember, ferritin, if you see, it is a water soluble non-heme compound of iron, and it is not detected by Pearl's reaction, and rather, to be very precise, there is no cytochemical method to detect ferritin. Okay, so it is a water soluble non-heme compound, whereas if you see the siderotic granule that I am talking about, which is mainly the hemosiderin variety, the non-heme iron, but it is hemosiderin, but it is very importantly a water insoluble complex, whereas the ferritin is a water soluble non-heme compound. Okay, now to revise some important points, iron, when it is absorbed from the body, okay, when it enters the circulation, it cannot be in the free form, it is with transferrin. Okay, and with the help of transferrin, the iron, okay, they enter the bone marrow and they reach the erythroblast. Now inside the erythroblast, majority of this iron is converted into heme, whereas the remaining non-heme iron, they are stored in the form of ferritin. Okay, but a portion, okay, very less amount of ferritin can undergo degradation, and once it degrades, it can lead to the formation of some amount of hemosiderin, okay, which can happen normally also. And this hemosiderin can be expelled out of the erythroblast, and then they are phagocytosed by the macrophages, and some amount is also lying freely in the in the bone marrow microenvironment. Okay, so basically this is what happens normally. Okay, this is what happens normally, and some amount of hemosiderin might also be present inside of the erythroblast. Okay, very less amount. This is not very significant. Okay, so this is what is the normal pattern, and this is how normally iron is metabolized, then it is stored, and how ferritin and how hemosiderin is getting formed. Okay. Now remember, what is a sideroblast? As I told you, whenever an erythroblast is containing siderotic granule or siderotic material, that is nothing but hemosiderin. Okay, we are calling them as a sideroblast. Now sideroblast is not always pathological. So there are three types of sideroblast. In some of the books they are calling them type 1, 2 and 3, and in some of the books they are not calling them anything. Okay, they are just saying that some of them are present here, some of them are present here and here in this condition. So for simplicity, there are three types of sideroblasts. So type 1 sideroblast is completely normal, whereas the type 2 sideroblast and type 3 sideroblast, they are abnormal. Okay, type 2 and type 3 are abnormal, and I will discuss each one of them in details. Okay, So type 1 sideroblast, if you see, they are basically present normally in 30 to 50% of late erythroblast inside the bone marrow and also inside the marrow reticulocyte. However, remember, normally no siderotic granules are present inside the RBCs normally. So normally in mature RBCs inside the peripheral circulation, you will not see presence of siderotic granules. So there is no normal siderocyte. There is no concept of normal siderocyte. Remember this point. Now I will tell you why. Now, as you can see that inside the marrow reticulocyte, okay, some amount of siderotic granules are present which is containing non-heme iron in the form of hemosiderin. Now, whenever this reticulocyte is coming in the peripheral circulation, in a very short period of time, they are sequestered or trapped in the spleen. In the spleen. So they are trapped in the spleen, and inside the spleen, when this reticulocyte is trapped, they undergo maturation. So what is this maturation? That this particular reticulocyte containing siderotic granule, they are basically undergoing maturation. And what is this maturation? They are utilizing the iron in the form of siderotic granule to form complete heme synthesis. Okay, so complete hemoglobin synthesis happens, and this reticulocyte inside the spleen, they matures to form a mature RBC which is not containing any siderotic granule. That siderotic granule is completely utilized, okay, when the reticulocyte is transforming into mature RBC inside the spleen. So that is why normally inside the peripheral blood circulation, you will not see a siderocyte. Okay, it will be seen in conditions where a person has undergone splenectomy. So post splenectomy, what happens that these RBCs or these reticulocytes, okay, which are containing siderotic granules, they are seen in the circulation. Okay, why? If the spleen is not there. Else, if the spleen is normally functioning, you will not see any any RBC which is containing, or any such cell which is containing siderotic granule will not be seen. So that is why normally, okay, sideroblast is the type 1 sideroblast or the normal sideroblast constituting 30 to 50% of the erythroblast in the bone marrow, and also some amount of the siderotic granules are present in the marrow reticulocytes, which when enters the circulation, it is sequestered by the spleen, and over there they mature to form the mature RBCs. I already told you what maturation occurs, so I am not repeating again. Remember, very few scattered siderotic granules are present, and they stain very faintly, and they are very difficult to see by light microscopy. So this siderotic granule which is present inside the erythroblast, this is very few and they are quite scattered, and they stain very faintly. So they are not of much significance normally. Okay, but there are two other types of sideroblast, that is type 2 and type 3. Now type 2 sideroblast is an abnormal sideroblast which is formed in conditions of iron overload. And over here, one important thing that you have to understand, that the percentage of sideroblast, okay, they increase in proportion to the degree of transference saturation, or in other terms, in proportion to the degree of amount of available iron. So in iron overload condition, more amount of iron is available, so more amount of siderotic granules are formed, so more amount of erythroblast containing increased amount of sideroblast are seen. So the percentage of sideroblast, like for example, normally 30 to 50% is there. Over here might be 80%, 70% to 80% sideroblast are containing. Okay, so over here the increase in the number of sideroblasts is proportional to the amount of iron available or to the transference saturation. Okay, so over here both of them are going together. So there is a reason, because increased iron is available, so increased percentage of sideroblast containing siderotic granules are also there. Okay, and this is seen in conditions of iron overload like hemolytic anemia, hemochromatosis, hemosiderosis, transfusion related. So how are the siderotic granules different from those of type 1 sideroblast? Why? Because over here the siderotic granules, okay, unlike the type 1 sideroblast, over here the siderotic granules are more numerous and they are larger as compared to the normally type 1 sideroblast. Okay, and over here, so over here, remember, this is the important point. Okay, both in type 2 and type 3, okay, the siderotic granules, they are numerous and they are much larger as compared to the ones which are present in type 1 sideroblast. So I hope this condition or this concept is crystal clear. Now type 3 sideroblast, okay, as I told you, they are also abnormal just like the type 2. But over here the major difference is that there is a disproportionate increase in the percentage of sideroblast when you compare to the transference saturation. So for example, the amount of iron available is less only, but in comparison to the amount of iron available or transference saturation, the increase in the number of sideroblast is quite more. Okay, so this is in type 3 sideroblast, which is mainly present in conditions of abnormal iron metabolism. So it occurs in condition where hemoglobin synthesis is impaired. So heme synthesis is affected over here, and there is a disproportionate increase in the percentage of sideroblast as compared to transference saturation. Okay, over here, because of abnormal iron metabolism, the siderotic granules, they start depositing in the mitochondria. Okay, and they are basically mainly seen, such siderotic granules, they are seen in case of sideroblastic anemia. So type 3 abnormal sideroblasts are seen in conditions of sideroblastic anemia. So just like the type 2, over here the siderotic granules are more numerous and they are larger. Okay, they are larger than the normally few and scattered siderotic granules. So how do you differentiate between type 2 and type 3 morphologically? Now type 2 sideroblast, if you look at the distribution of the siderotic granules, they are normal. Normal distribution means that they are scattered distribution. Whereas the type 3 sideroblast, okay, over here you will see that the distribution is perinuclear. They form a collar around the nucleus. So there is a perinuclear distribution. So if you see over here, I am going to show you with this help of this diagram over here. So normally if you see the type 1 sideroblast, there are less than 5 siderotic granules in the cytoplasm, as we can appreciate over here. And they are faint, they are scattered, they are not even very large. But the type 2 granules, okay, they are much more larger and they are more numerous compared to the type 1. But over here again, just like the type 1, they are scattered. So there are more than 5 granules, but they are not perinuclear. The distribution is not around the nucleus, they are scattered. Okay, whereas in conditions of abnormal iron metabolism, you encounter type 3 sideroblast, which is characterized by the presence of more than equal to 5 granules, which is covering at least 1/3 the circumference of the nucleus. Okay, and such type 3 sideroblasts, they are called as ring sideroblasts, which is classically seen in sideroblastic anemia. So I hope this concept is crystal clear. What is type 1, type 2, type 3 sideroblast? Okay, I hope this is crystal clear to everyone. Now you must be thinking that why, sir, you are telling us so many things, because this concept is very, very important and a lot of Viva questions are asked to you. First question will be asked, what are siderocytes? What is sideroblast? Is sideroblast normal? Which level, which type of sideroblast is normal? Okay, and what are type 2, what are type 3 sideroblasts, or what are sideroblasts associated with increased iron overload, and what are sideroblasts associated with abnormal iron metabolism, and how do you differentiate? So I have discussed in details and compared and contrasted between them with the help of diagram as well, and I have also shown you the different conditions where you will encounter them. Okay, now basically, what is the etiology? What is the etiology of sideroblastic anemia? We have already discussed under the heading of sideroblast. This is just a repetition. So you can see sideroblastic anemia or ring sideroblast in conditions of hereditary sideroblastic anemia and certain acquired conditions like secondary to hematological malignancies like leukemias, mainly AML, M6, erythroleukemia, or therapy-related AML. Okay, also in myeloproliferative neoplasm like MPF. Okay, that is primary myelofibrosis, multiple myeloma, and even in MDS. Okay, then secondary to certain drugs like antitubercular drugs like pyrazinamide, isoniazid, okay, or B6 antagonist if you are using, or certain antibiotics like chloramphenicol, or secondary to lead or alcohol. Certain autoimmune conditions also sometimes shows like rheumatoid arthritis and SLE. Now just one important thing, morphologically, how you can know what can be the cause. Now remember, in case of hematological malignancies, usually the erythroblast in all stage of maturity are affected, or they will show ring sideroblast. Whereas in hereditary and in conditions which are secondary to the drugs, okay, more mature forms of erythroblast are affected. This is how morphologically you can guess, the probable cause of ring sideroblast. Okay. Okay, so with this I have given you a basic idea has been given with regards to sideroblast and siderocytes, and what is siderotic granule. They ask you in the exam, what is this granule? So this is a non-heme water insoluble form of iron, which is basically hemosiderin. Okay, okay. Now, very importantly, you have to understand the method for staining siderotic granule. It is the same that we are using for, staining the iron granules, in case of bone marrow routine iron staining that we are doing, the pearl stain. So, it can be done on both PBS as well as the bone marrow films, but mostly they are done on the bone marrow films. So, you air dry the films, that is followed by methanol fixation for 10 to 20 minutes. After drying, you place the slides in solution of 10 gram per liter potassium ferrocyanide in 0.1 mole per liter HCl. Then you keep it for 10 minutes at 20 degrees centigrade you keep. You wash well in running tap water for 20 minutes and then rinse thoroughly. Counter stain with 1 gram per liter either aqueous neutral red or eosin for 10 to 15 seconds. For quality control, a positive bone marrow film is always stained together with a test film of the test slide, whatever we are using. Okay. So as we have already mentioned previously that if these siderotic granules are present, then when we are doing the pulse stain, in that situation you will get a blue colored ferrocyanide, which is a positive Prussian blue reaction, the pulse reaction. Okay. And if you carry out a Romanovsky staining, whether it be in the PBS or in the bone marrow, they appear as basophilic granules and they are also known as Pappenheimer bodies. Okay. 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 Now, something more I would like to add, that in conditions of anemia of chronic disease, the iron stores may be increased, okay, with increased siderotic granule, that is hemosiderin, in the macrophages but little or none in the erythroblast. So this is the morphological feature in AOCD if they are associated with increased iron stores. Okay, for example, in conditions of chronic infection. Okay, whereas in thalassemia major or intermedia and some forms of congenital dyserythropoietic anemia, in addition to increased siderotic granules in the erythroblast, you also have increased amount of this form of siderotic granules inside the macrophages. So there is a marked increase in the storage iron in the macrophages. Okay. Now remember one important point, that there are no cytochemical stain which can demonstrate ferritin. This is a very, very important MCQ. This is asked. Which cytochemical stain can demonstrate ferritin? You have to say that there are no cytochemical stain to demonstrate ferritin. So this is basically, a bone marrow film. As you can appreciate over here, this is one important ring sideroblast. This is another ring sideroblast. So you can see that there are 5 or more such granules. Some of them are quite big and they are quite numerous. Okay, so they are not normal and they are surrounding the nucleus. So they are ring sideroblast. Okay, especially seen in sideroblastic anemia. Okay, this is the high power view of the same. Okay. And this is basically what I wanted to highlight to you. This is basically the presence of Pappenheimer bodies over here. So you can see that in the peripheral blood smear staining, you can see the presence in the MGG, which is the Romanovsky stain. You can see basophilic granules over here. You can see the presence of numerous basophilic granules inside the cytoplasm over here, which is called as Pappenheimer bodies. Okay, using the pulse stain, again they can be highlighted over here as well. Okay, and these cells in the PBS which are showing, they are called as siderocytes, usually seen post splenectomy. Pappenheimer bodies can be seen. Okay. Okay. Now this is the first important thing, that is the highlighting the siderotic granules in different conditions that we have seen. This is the first important cytochemical stain which is used in erythrocyte cytochemistry. The second major group over here that we are going to study over here is the highlighting of hemoglobin derivatives cytochemically. Okay, so under this, the two most important things that we have to highlight in the under the erythrocyte cytochemistry is the presence of Heinz bodies in the RBCs and the fetal hemoglobin. Okay, the RBCs containing the fetal hemoglobin or HbF. Okay, and others are carboxyhemoglobin, methemoglobin, and highlighting HbS and other variants. So first we will read about highlighting the Heinz bodies in the RBC. So first you have to understand what is a Heinz body. A Heinz body, if you remember, we have discussed in details in under the heading of GCSPD deficiency. So Heinz bodies, if you see, they represents precipitates of globin chains usually attached to the RBC membrane. So they are a late sign of oxidative damage and represent end product of hemoglobin degradation. So what are the conditions where you will come across Heinz bodies in humans? Especially you will come across them in GCSPD deficiency or in unstable hemoglobin disease or secondary to chemical poisoning or drug toxicity. So remember that these Heinz bodies, they are not visible with routine peripheral blood smear staining. That is, in routine Romanovsky dyes that we are using, the Leishman staining, MG staining, we will not, Heinz bodies are not visible with routine Romanovsky dyes. Okay, it is highlighted with the help of supravital staining like methyl crystal violet or methyl violet or mu methylene blue or bromocresol green. With crystal violet, the stain is quite intense. Okay, and that is preferred for highlighting the Heinz bodies. Now remember, they morphologically one or more such Heinz bodies may be present in a single cell, approximately 1 to 3 micrometer in diameter. Okay, usually they are present close to the cell membrane and they may cause protrusion of the membrane. I will show you with the help of diagram. and sometimes it is present as 1 to 3 granules like that, but sometimes they can be quite numerous as well. I will show you with the help of diagram. Okay. Now, before I go to the staining process, I would like to tell you that there is one differential diagnosis of a Heinz body, that is the Howell-Jolly body, which is seen basically following splenectomy, and they are visible. How do you differentiate? Remember, Heinz body, they are not visible under the routine Romanovsky stained smear, whereas Howell-Jolly bodies, they are visible in the routine Romanovsky stained peripheral blood smear, and they appear as small round purple staining nuclear remnant located peripherally in the RBCs. Okay. Whereas for staining the Heinz bodies, we require supravital stain. So over here we will use methyl violet. So dissolve 0.5 gram of methyl violet in 100 ml of 9 gram per liter NaCl and filter. So you add 1 volume of blood, okay, blood collected in anticoagulant vial. You add 1 volume of blood to 4 volumes of methyl violet solution, and you allow the suspension to stand for 10 minutes at room temperature. Prepare films and allow the slide to dry and place a cover slip. Heinz bodies, they stain intense purple. I will show you with the help of diagram. Now remember, with methyl violet, the stain is intense purple, but the stain is less intense with new methylene blue or with your bromocresol green. Okay. Now, in case of beta thalassemia major also, methyl violet staining in the bone marrow films, okay, they can highlight precipitates of alpha chains, not only alpha chain but also beta chains in case of alpha thalassemia, which appear basically as large irregular inclusions in late normoblast, usually present singly and closely adhering to the nucleus. Okay. So this is about the Heinz bodies and how to differentiate it from Howell-Jolly bodies, and I will show you with the help of diagram, okay, how they look like. So if you can appreciate over here, this is the Howell-Jolly body. So you see in the usual Romanovsky stain, the Howell-Jolly bodies, they appear, okay, in the periphery of the RBCs, whereas if you see in the supravital staining, okay, supravital stain, okay, new methylene blue or bromocresol green or in crystal violet staining, you can see intense purple staining of this. Now over here they are present singly, and you can see they are as if they are protruding out of the nucleus of the membrane, RBC membrane. So they seem as if they are protruding out of the membrane. Okay, and you can see multiple forms. You can see one or more also. In some conditions, you can see multiple such Heinz bodies inside the RBCs over here. As you can appreciate, some of them, they are also protruding out. Okay. They are the half ghost cells, as you can appreciate, which is characteristic of G6PD deficiency. So this is the condition of G6PD deficiency, as we can appreciate over here. Next, we are going to read about, highlighting the fetal hemoglobin cytochemically. So it is identified by acid elution cytochemical method of Klehor et al. Okay, and it is a very sensitive technique. So it is based on the principle of identification of cells which are containing HbF based on the fact that they resist acid elution or acid denaturation to a greater extent than those RBCs which are containing normal adult hemoglobin. This is the basis of acid elution test. Okay, so RBCs which are containing fetal hemoglobin, they appear isolated and they are darkly stained cells among background of pale staining ghost cells. Okay, now acid elution is carried out as an acidic pH of 1.5. So how do you do the staining? You prepare fresh air dried films or peripheral blood smears. Okay, immediately after drying, fix the films, okay, for 5 minutes in 80% ethanol in Copland jar. You rinse the slides rapidly in water and stand them vertically on blotting paper for 10 minutes to dry. Place slides for 20 seconds in Copland jar which is containing elution solution. Now what is the composition? How do you make different solutions? You will not be able to remember, but at least remember that elution solution is containing hematoxylin, iron chloride, and most importantly HCl, taking the pH to 1.5. Then wash the slides thoroughly in water and finally place them in counter stain for 2 minutes. Counter stains can be aqueous erythrocin or aqueous eosin. Rinse in tap water and allow them to dry. So what is the major use of this test? As you remember, we have already discussed this under the approach to hereditary hemolytic disorders. So use of this test, first important thing is the identification and quantification of feto-maternal hemorrhage. Okay, and secondly, in intercellular distribution of HbF, like for example in conditions of hereditary persistence of hemoglobin, if you see fetal hemoglobin, you will see that there is a pancellular distribution of RBCs containing hemoglobin, whereas in other conditions like delta beta thalassemia, in those conditions if you see there is a heterocellular distribution. So I have already discussed about that in details in my lecture on approach to hereditary hemoglobin, hereditary hemolytic anemia. So I'm not discussing them in detail, but just saying in short, because cytochemistry is a vast topic and we cannot discuss individually each and everything. Okay. So with this we have completed the the cytochemical evaluation of fetal hemoglobin. Next we are going to see what are the other uses, or how cytochemically we can also characterize the presence of carboxy and methemoglobin. But remember, though they can be demonstrated cytochemically, but their demonstration is of little practical significance now, so they are not carried out. And for HBS and other hemoglobin variants also, cytochemical analysis is not involved, because most of them are now detected with the help of either electrophoresis or HPLC. So it is always there. So right now we are not using this method, but if anyone is asking, so immunodiffusion techniques using specific antibody can be used to detect HBS, HbA2 and HbF, and via immunofluorescence also, via using this FITC stain, you can also detect the hemoglobin S and other hemoglobin variant, but these are not of practical significance. Okay, I have just mentioned here to complete the list. And lastly, I would like to conclude by showing you this. So this is the Kleohar-Betke's test over here. The fetal cells which is resisting acid denaturation of HbF, so they are appearing darker in color, okay, bright pink color over here, whereas the maternal ghost cells which are containing the HbA, they are not able to resist and they are undergoing denaturation by the acid, so they are appearing as faintly stained or lightly stained maternal ghost cells. Okay, so this is one example of the PBS, as you can see. So these are the fetal RBCs containing the HbF, okay, fetal RBCs, okay, and the other they were not able to resist acid denaturation, so they are basically appearing as the ghost cells, as we can appreciate over here. Maternal ghost cells can be appreciated over here. So with this, we have discussed in details about the erythrocyte cytochemistry. Hope you have enjoyed this lecture. Thank you very much for watching this particular video.